Good afternoon. I'm Amory Fiore, and I am a neurosurgeon at ONS, and I'm going to talk to you today about laminectomy versus discectomy options for back pain. I'm a spine surgeon at ONS. So just before we even really get going, it's a little bit of a misnomer because most of what I'm talking about is really about options for treating leg pain or back and leg pain. Low back pain as an isolated problem is really a completely different problem that these types of surgeries don't really apply to. So it is pain that comes from the back, and so we call it back pain, but it's really more nerve pain related to nerve compression, which people feel more in the legs. So I'll just give you a little overview of what I'm going to talk about. So surgery is all about anatomy, so I'm going to give you some anatomy lessons, and hopefully it'll be understandable, but it's really critical to understanding what comes next. And then we'll talk about two conditions: lumbar disc herniations and lumbar stenosis. I'll show you the imaging, which is very important, and how we evaluate this and make decisions. And then we'll talk about non-surgical treatments for each problem and surgical treatments for each problem. So in terms of anatomy, so the human nervous system is composed of the central nervous system, which is the brain and the spinal cord. So brain and the spinal cord, which connects to the brain, and then the peripheral nervous system, which basically is everything else, which starts with the spinal nerves, which are the individual nerve roots that come off of the spinal cord and then go out to the rest of your body. So sensory information like pain, touch sensation, temperature, vibration, joint position travel from sensory receptors in your body, in your fingertips, your toes, your skin, everywhere. And it travels through the peripheral nervous system, through the peripheral nerves, through the spinal cord, and then up to the brain, which is where you perceive any sensation. And going the other way, motor commands travel from the brain down to the spinal cord and the peripheral nervous system to muscle. And so if your mind tells you to move your arm, your brain sends a command through the spinal cord and peripheral nerves to your muscles in your arm, which makes the muscle fire. The spinal cord is like the brain. It's extremely delicate and complex. The peripheral nerves are a little more robust and a little simpler, although not indelicate. So in terms of spinal anatomy, this is the entire spine here. You have a front view, a side view, and a back view. And so there are 7 cervical vertebrae, 12 thoracic vertebrae, the mid-back, and 5 lumbar vertebrae, and the sacrum, which is essentially the tailbone and the base of the spine and part of your pelvis. So each vertebrae is one of the individual bones in the spine. And between each 2 vertebrae, there is a cartilage disc at each level. So the nerves are numbered based on the vertebral bodies on the vertebrae numbers. So the L1 nerve comes out below the L1 bone, the L2 nerve comes out below the L2 bone, etc. And different spinal nerves go to different parts of the body. And in the legs, which we're going to be talking about today, primarily it's L1, L2, L3, L4, L5, and S1 that are the nerves that are involved, which are nerves that come out in the lumbar spine. This is another view of the spinal cord showing all the nerve roots which come out, and then in the lumbar spine they're going to come out and form the different nerves that go down to your legs, which are basically two nerves. One is the sciatic nerve, which is the big nerve that goes down to your leg, but there's also the femoral nerve and a few other nerves. And in the lumbar spine, the spinal cord ends at the L1 level, and below that is the cauda equina, which is the nerves that come off the spinal cord. And so there's no spinal cord from about L1 down, which is critical in terms of assessing and treating these kinds of disorders, because if you have to work around the spinal cord, it's a much more delicate situation, and it changes surgical approaches. So this is the lumbar spine anatomy. So this is a cross-sectional view of one vertebral body, and this is a side view of the spine with bone, disc, bone. This is a cross-section of the disc, or the intervertebral disc, which is the cartilage joint. And this is a view looking from the back. And so I've circled the lamina, which is here and here. And so laminectomy means removing the lamina, or removing part of the lamina. And so, that's, the name of the surgery in certain situations, but it's a part of different surgeries for different conditions, but that's why it's called what it is. And sometimes people are confused whether they had a laminectomy or a discectomy, or someone recommended a laminectomy or discectomy. Different people use different terms, but essentially anytime you're removing part of the lamina, it's a laminectomy. This is a 3D view here where you can see the sac of nerves that comes down inside the spine from the spinal cord. And then at each joint level, you have nerves on both sides, which go out, down, out into your legs. And again, you can see the lamina here, which I've circled. So in terms of the disc, this is an important part of the discussion. So that the intervertebral disc is the cartilage joint between each two vertebral bodies. And it has essentially two parts. It has the annulus, which is the outer part, and the nucleus, which is the inner part. And it's all cartilage, but it's two different kinds of cartilage. And so the annulus is like layers of an onion. It's layers of tough, leathery cartilage that is in rings. And basically that attaches to the bones above and below. And the nucleus is contained within that. And that's sort of a less structural kind of cartilage that, people will call the shock absorber. But it does allow for some absorption of load in the spine, but it also doesn't have the same structural sort of integrity as the annulus. And so a lot of people use the jelly donut analogy, which I don't really like, but I thought I would mention because people talk about it all the time. So, when people talk about a disc herniation, they talk about the jelly and the donut being the nucleus, and the donut part being the annulus. And so if you have a herniation of a disc, a piece of the nucleus comes out, or a piece of the jelly comes out of the donut, which in some way makes sense, but in reality, the disc is solid tissue, and the nucleus is more like crab meat. If it were jelly, it probably wouldn't be a problem because it wouldn't really push on anything. But that is where the analogy comes from. So I want to get a normal imaging of the spine. And so this is a lumbar spine MRI. So MRI is the standard that we use to assess spinal disorders, especially if we're considering surgical treatment. And so this is a side view here. This is the front, back, head, and feet. And so you can see the bones and then the discs between. This is the spinal cord, and then the nerves coming off the spinal cord traveling down inside the spine. And this is a schematic representation of this just to make some sense of what you're seeing on the left. But we're seeing bone, disc, bone, spinal nerves, essentially the same kind of a view here. So this is a cross-sectional view of the lumbar spine, which is the other standard view of the spine. There's two views, the one that you saw previously, the sagittal view, and this, which is we call the axial view, which is a cross-sectional view. So in this view, this would be if someone were laying on their back on a table and I was standing at their feet and looking up through them. And so we're seeing a cross-sectional image. So this is the front, back, right, and left. And by convention, the right side is on the left side. That's just the way it is. And here, this is a schematic representation of that. So you can see the disc and the nucleus and the annulus, and then the sac of nerves and the nerves coming off. And then you have bone in the back, you have the lamina and the facet joints. And so here you can see this is the sac of nerves within the spine, and this is the bone in back, the lamina primarily, but also the facet joints, which are the joints in the back of the spine. So the first condition I'll talk about is a lumbar disc herniation. And so this is a three-dimensional view of a lumbar disc herniation. And what happens in a lumbar disc herniation is the disc breaks down and a piece of the nucleus comes out and pushes on a nerve. So for that to happen, two things have to happen. The nucleus has to break down in some way so that pieces of it can come out. And then the annulus has to tear to make a hole to allow the nucleus out, because the annulus contains everything within the disc. And so, you know, this is a representation of that. And this is nucleus, which has come out, which is pushing on nerves, you know, within the spinal canal. And you can have herniations in different areas. And you can have a herniation within the spinal canal here, which is more towards the middle. You could have a herniation far out on the outside, which is actually not going to get the nerves in the spinal canal, but will get the nerve coming out. So depending on where it is, it's going to cause different symptoms, and the approach to that will be different. So in terms of lumbar disc herniations, they are degenerative in nature. They can occur due to trauma, but you know, commonly people have disc herniations from bending and heavy lifting. The peak incidence is between about age 30 and age 50, so it's a disorder of you know, relatively younger people. And the reason it's a problem is because the disc herniation, the cartilage that comes out is then squeezing a nerve in the spine, and by direct compression of the spinal nerve, that causes pain and other symptoms. And also because there's a lot of inflammation with any kind of injury, the inflammation also causes a lot of discomfort. And people often get confused by the terminology, whether they have a herniation or a bulge or an extrusion or you know, any number of different descriptions of a disc problem. And you know, the terminology is actually confusing and it's not really important. I just showed these two pictures to show you that there's a lot of different terms you can use. So a prolapse is another word for a disc bulge, where some disc is sticking out, but the annulus may be sort of stretched out and partially torn, but the nucleus is still contained. An extrusion is, you know, where the nucleus is coming through the annulus where it's not really contained. A sequestration is if a piece of the disc can sort of break free from the rest of the disc and push on the nerves. A bulging disc is generally, to a spine surgeon, a disc which is sticking out a little bit towards the nerves, but not really doing anything, not really pushing on the nerves. And, you know, a herniated disc is usually a more significant, you know, protrusion of the disc where it's more likely to be pushing on the nerves. But the big question is really, is it pushing on a nerve or not? Because if you have a bulging disc and, you know, it's right down the middle and the nerves around it have room to get around it, that's not going to give you nerve pain. It's when the nerves get compressed that people get the pain, which causes them to seek, you know, medical treatment. So in terms of symptoms, the typical symptoms of a lumbar disc herniation are first pain, which people describe as a stabbing pain or an electric pain or burning pain or an excruciating pain. And people describe it as one of the worst pains that they can have. You can also have sensory symptoms, so numbness, so loss of sensation to touch, tingling, pins and needles. Some people describe vibrating sensations. People describe it in different ways. Some people describe a sensation of water pouring down their leg or down their back or leg. And then you can also have motor dysfunction, which means weakness. And so the typical weakness from a herniated disc is a foot drop, and that basically is illustrated here. So normally you can bend your foot up and down at the ankle. If you have a foot drop, you lose the ability to do that because the nerve going to the anterior tibialis muscle, which bends the foot up, is being compressed, and so the signal's not getting through to the muscle to make that muscle work. And so typically an L4-5 disc, or sometimes an L5-S1 disc, will give you a foot drop in some cases. And so that's a very sort of classic symptom of a lower lumbar disc herniation. So here we have a illustration of what happens when you have a herniation. So here you have the nucleus, which is coming out, the annulus, which is torn, and the nerve root coming off the spine, off the sac of nerves, really is being compressed. So the nerve is being squeezed. That's very painful and can cause some weakness and numbness. And there's also a lot of inflammation associated with that. And this is an MRI image of a herniated disc in the lumbar spine. And so, this is the sac of nerves, this space here. I've circled the herniation, which is on the right side. So on the left side, the nerve is here. That would be the L5 nerve starting to head out of the spine, and that's where it should be. But on the right side, this is all herniated disc. So that's all cartilage from within the disc, which is now pushing on the nerves. And so the L5 nerve, which is there on this side, is somewhere in here getting squashed up against the bone. And so the nerve's really being squeezed, and that's clearly going to cause, a lot of symptoms, of nerve compression. So that would be a very typical MRI image of a lumbar disc herniation. This is another representation of disc herniation. This is a sagittal view, which is, as I showed you before, a view from the left side. So this is the space where the nerves are. The white is spinal fluid, which is essentially like water, which is within the sac that the nerves inside float in. And then the individual nerves, you don't always see very well, but those are individual nerves there. And so this is the L5-S1 disc. And so this is a large herniation where a big piece has come out and is pushing on the nerves. And then this is a cross-sectional view, which again is showing that on the right side, you have this large disc squeezing the nerves, pushing the nerves somewhere up into there. On the left side, the nerve is free and happy. So that would be a very typical lumbar disc herniation. So in terms of treatment for lumbar disc herniations, the initial treatment is generally non-surgical, and the standard treatments are physical therapy. And that can include many different things. There can be modalities such as heat ultrasound, electrical stimulation, massage. Exercises are a very important part of treatment. There are specific spine exercises which may alleviate pain by changing the alignment of the spine. There are specific spine exercises which may open up the space for the nerve a little bit, or get the disc off the nerve slightly to relieve pain. And then there are exercises that really focus on core strengthening and flexibility, which are very important for protecting your spine. And then ergonomic exercises too, because people bend and move and do things in the wrong way. And so physical therapy can retrain you to do things in the right way, in a way that's less likely to cause a problem or cause pain. And then there's other treatments such as dry needling, which are becoming more common, where it's sort of akin to acupuncture, but not exactly the same thing. But physical therapists do find this to be an effective treatment in many cases. NSAIDs are a mainstay of treatment, non-steroidal anti-inflammatory drugs, such as Advil, Aleve, and other prescription medications. And they do help with pain, and they work by reducing inflammation. I don't really consider them to be therapeutic in the sense that they're not fixing the problem, but they are, in some cases, effective for relieving pain associated with the condition. Oral steroids are very commonly used. Typically we use what's called a Medrol pack, methylprednisolone, or sometimes prednisone. So those are corticosteroid pills, which are a different kind of anti-inflammatory, which are much more effective and stronger anti-inflammatories, but do have a little bit of a risk of side effects. And if someone comes in with acute pain from a new disc herniation and there's a lot of inflammation, and you give them oral steroids, that will often help a lot with pain initially because it's so effective at reducing inflammation. Another treatment is epidural steroid injection, which a pain management doctor would do. So a pain doctor would basically inject steroid medication in the spine with x-ray guidance right in the area where the nerve is being squeezed. So instead of taking a pill with oral steroids that's going to your whole body, this is a steroid which is localized to the spine, and in some cases can be more effective for relieving pain. And it's a standard treatment, and sometimes it works very well. It doesn't always work. It's a little bit hit or miss. It's extremely safe, but sometimes people get good relief and sometimes they don't. It does not fix the underlying problem. It reduces inflammation and helps with pain temporarily. And then you have other alternative treatments such as chiropractic, spinal decompression, acupuncture, inversion tables, traction. Those are all things which can be effective. I don't want to get into that too much. I don't have a problem with chiropractic treatment. Sometimes it can be very effective. My first recommendation is typically going to be physical therapy, though, and I think that the exercise part of physical therapy is the most important part. So how do lumbar disc herniations get better? So the lumbar disc the cartilage in the lumbar disc has a lot of water in it. And what can happen over time is that piece of disc, which is pushing out and squeezing the nerve, can essentially dry out, shrink, and be reabsorbed by the body. So it can go away. And I think that's what happens most of the time when people get better. I think a lot of the time it's really time that makes people better more than anything else as the body heals and the disc shrinks away. With therapy, exercises, traction, you can get the disc away from the nerve a little bit and help relieve the symptoms. And, that can be helpful as well. I don't, people often ask, can I pull the disc back in with physical therapy? I don't really think that's so much the case. It does depend on the anatomy, and there's variations of anatomy of disc herniation. But, I think probably the disc is mostly shrinking over time with the body healing it. And an epidural injection does not shrink the disc at all. It reduces inflammation microscopically, but doesn't make the disc go away. But if an epidural injection works and gives you pain relief for a month or 2 months or 3 months, then that's buying you time for the body to heal itself. And so about 80% of disc herniations will resolve completely, in the first 3 months from the initial onset symptoms. So when non-surgical treatment fails, surgery is indicated. And, the reasons people do surgery are because they don't respond to non-surgical treatment, and 6 to 12 weeks is a reasonable time, for most practitioners to give non-surgical treatment to work before considering surgery. But the exact duration of the treatment depends on how bad the problem is, how much pain there is, how incapacitated the patient is. Some people have relatively mild symptoms. Other people have really, excruciating pain, and you can put up with mild pain a lot longer than you can put up with severe pain. And it's also a quality of life issue in terms of, how much it affects, your ability to just have a normal life. Some people have surgery early, in the first few weeks after onset of symptoms, because they have incapacitating or intolerable pain, or pain that prevents them from walking, or prevents them from working, or prevents them from caring for their children, or, participating in other activities of life that are essential. And so in a case where someone has very severe pain and they're in that condition, lumbar discectomy early on will often make them feel better faster than anything else. And, the effect is very quick. So it is very helpful for people in that situation. The third reason is if you have a neurologic deficit, which is really primarily weakness. So if you have a foot drop that's bad, if you can't bend your foot up at all, we know that sometimes that doesn't get better. And so we don't want to let that go too long, because we don't want the nerve to be damaged irreversibly, and we don't want the muscle to atrophy irreversibly, which are things that can happen. And so, if you have a severe foot drop, I'll tell you that you should have surgery, because I'm afraid that if we don't do it, that you're not going to get better. And it's possible for people to get better with a foot drop, and I've seen it happen. But I've also seen people not get better, because they've waited too long or prior to surgery. And the problem is everyone's different, and you can't predict for any individual patient whether or not they can get away with waiting longer or not having surgery, or whether they'll get better without surgery or not. So, we consider the worst case scenario in those situations. But mild weakness is pretty common, and depending on the degree of weakness, a lot of the time you can treat that non-surgically, and that'll get better. So just a little bit of weakness is not necessarily a reason that you have to have surgery. So if I do surgery for a lumbar disc herniation, I will do a minimally invasive microdiscectomy, which is very effective. So, again, here we have a MRI showing a left-sided disc herniation compressing the nerve root. So here, this is the backside. That's actually the skin on the back. So this is all muscle here. And so to get down to the spine, we have to go through that. And with a minimally invasive procedure, what we do is we make a small incision, and we start with a needle that goes down to the spine. And then we put these dilating tubes over that, and they're progressively larger in terms of diameter. And so what they're doing is they're splitting the muscle, and muscle likes to be split. It's very easy to split muscle without cutting the fibers, and it doesn't really damage it very much. And so what you can do is you can split the muscle until you get to a point where you can put a tube that you can work through, which, is this. And so now here, just in case you're confused, this is the backside here, the way an MRI looks. This is the backside here, which is the way it looks when you're on the operating table, because I'm up here working down from the back. But so this is the tube that I work through, which is typically 18 millimeters in diameter. And so I just have to make an incision long enough to get that tube down there, which is a small incision. And then once I get down there, I can do a small laminectomy, remove a little bit of bone and ligament to get to where the disc is, and take out the part of the disc that's pushing on the nerve. If I do a discectomy, I will, in almost every case, remove most of the nucleus, and we really don't remove any of the annulus because you don't need to, and it's structurally important. How much nucleus versus annulus there is in any given patient, I think, can vary a little bit. But, I think probably in total, you're probably removing somewhere along the line of 30% of the disc. It's not the whole disc. People often ask that. The bottom line is people do fine with a little bit less disc. It doesn't cause any major problem. The surgery works very well. The reason that we remove most of the nucleus is because we want to prevent a recurrent herniation. We want to prevent another piece from coming out and doing the same thing. And, it's felt by most surgeons that if you clean out the inside of the disc, you take out any loose pieces, that there's less likely to be a recurrent herniation. And so here, this is just to illustrate the laminectomy part. So if you do a discectomy, you have to do a laminectomy. So I'm working down from the back, and to get to the spinal canal, I have to remove a little bit of the lamina here to make a window to get in there. And you also have to remove a little bit of ligament just to get down there. And so anytime you do a standard discectomy, you're doing a little bit of a laminectomy. And, again, sometimes people are told they have a laminectomy, but they really had a discectomy. So that's where a little bit of the confusion comes from. If you're doing surgery for spinal stenosis, that's typically going to require a little bit of a larger laminectomy than for a discectomy. So if you do a minimally invasive discectomy, it's outpatient surgery. It takes about an hour plus general anesthesia, so maybe 2 hours in the operating room. If you came in at 6:30 for a 7:30 surgery, you'd typically be out by noon. There's no stitches or staples to remove. I use glue on the skin, which is like crazy glue. This is a penny. That's, the size of the incision. It's a very small incision. I use a little waterproof dressing. You can shower the next day. there's no maintenance of the dressing or dressing changes really that you need to do. The beauty of the minimally invasive discectomy is when you're splitting the muscle and not really cutting it, the wounds heal faster. So the wounds heal faster, and there's a lot less bleeding. So anytime you do surgery, there's always a little bit of bleeding that can occur, and you can have some oozing through the skin. And if you have any oozing, the more oozing there is, the more likely it is you'll have an infection. When I do a minimally invasive discectomy, there's almost never any bleeding at all through the skin. And it's a very dry wound that doesn't leak, and the infection risk, I think, is much lower because of that. Because it's minimally invasive, there is a little bit less pain and a shorter recovery. We get you walking the same day, and you can walk as much as you want, and if you feel good, more walking is better. So there's no limit on that. A lot of times people, when they have a pinched nerve from a herniated disc, will feel immediate improvement or even resolution of the nerve pain, right the day after the surgery, or even sometimes the same day. Your back will hurt from the surgery, and it can, be significant for 1 to 2 weeks. You may need to be on pain medicine, typically not for more than a few days, but usually after the first few weeks, you're just sore or stiff, but not too bad. I usually start people on physical therapy after about 4 to 6 weeks, and I think that's important and helpful in terms of conditioning, recovery, and preventing any recurrences. Depending on how the patient's doing, I'll let them do more or less earlier, but if you're doing well, you could do an elliptical or an exercise bike or some light weights, and maybe swimming after 4 to 6 weeks after the surgery. What I really tell people they can't do at all is no bending at the waist, no lifting anything heavy. That is the single activity which puts the most stress on the disc, and is the most likely thing to cause another herniation. In terms of return to normal activity like sports, like golf, tennis, running, if you're doing well at 3 months, I think you can start at that point. And overall, it's a very effective, successful operation. The success rate greater than 95%. I think it's closer to 98%, but it really does work well. So what are the risks? The big risk really is that you could have another herniation. And we're not fusing that disc. We're doing a small operation that's very effective for relieving pain, but you still have a joint that's moving there, and it's still a weakened joint. And there's nothing you can do to make it 100% normal and robust like the day you were born. So there's a chance you could have another herniation, another piece can come out. And if you look at the literature, the numbers are all over the place. It's somewhere between 1 and 21% of people will have a herniation again sooner or later. I think probably 10% is a reasonable number. That's what I tell people. It does happen. It doesn't happen a lot. If it does happen, typically in most cases, if you have to, you can do the same procedure again, and it works equally well. The only way you can prevent a herniation after discectomy with certainty is to fuse the disc, which is a much bigger operation and not really the appropriate operation to do for that condition. There's a couple of percent of the time you can need to have surgery early on for bleeding or an infection or a spinal fluid leak. That's quite uncommon, but happens occasionally. And you can have problems related to anesthesia or related to underlying medical conditions, your heart, your lungs, things like that. And those are quite uncommon, particularly in healthy patients. So what do you do after you have a discectomy to prevent another problem? The most important thing is your weight. So if you're overweight, you got to lose weight. You want your weight to be optimal. The more weight you carry, the more stress there is on their back. The more overweight you are, the higher there is a risk of recurrence of another herniation. And overweight people after discectomy tend to be much more likely to have back pain than people that are not overweight. And so that's really the most important thing, and it's very difficult to achieve for a lot of people, but you got to do it, try. It's also important for your general health. As you get older, it'll affect how long you can live. Core strength is very important, strengthening all the muscles around your spine, your abs, your hips, everything to protect your spine. Flexibility in your hips and your legs is very important, and just general overall fitness. And then the other thing is proper ergonomics, so bending and lifting really. So you want to be careful with that. Bending and lifting heavy things like rocks and air conditioners is never good for anybody. And if you do it wrong enough times, you're going to have a problem, sooner or later. So you want to really be careful with that. And typically a physical therapist will show you how to do that and how not to do it. So now I'll move on to lumbar stenosis. So stenosis, according to Merriam-Webster, is a narrowing or constriction of a bodily passage or orifice. And lumbar stenosis is a narrowing of the lumbar spinal canal due to degenerative changes causing facet joint and ligament hypertrophy, as well as disc bulging and or bone spur formation, which is all a way to describe arthritis, which is joint degeneration that occurs with aging. And it's just essentially normal wear and tear that can sometimes lead to nerve compression. And as you get older, it becomes more common. So this is really more a disease of older people, but can occur also in younger people as well. On the left here, you have a illustration of lumbar stenosis. So these are the facet joints, which are on the back side of the spine. And so I have the circles here. This is the left facet joint, and then you also have the right facet joint. So between every two bones in the spine, you have a facet joint on either side. And these are lined with cartilage and ligament. And also there is some ligament that goes between the bones here, between the lamina. And when you get stenosis, primarily the facet joints, when they get arthritic, enlarge, and the ligament starts to get bigger or hypertrophy. And the overall result is that everything pushes in on the nerves. And so the second nerves get squeezed. And stenosis also can, be due to, disc degeneration as well. So the disc can bulge back in, and bone spurs can form along the disc with arthritis, and that can also narrow the space for the nerves. But, primarily classically it's considered to be due to enlargement or hypertrophy of the facet joints and ligaments in the spine. So here, this is imaging of lumbar stenosis. So on the left, this is a normal axial image of the spine. You can see the space for the nerves here. So the white is spinal fluid, which is the fluid that the nerves float in. The dots are the individual nerves. Everything is very happy here. That's normal. This is severe spinal stenosis. So this here used to look like that. And so these facet joints are enlarged and pushing in, and so the nerves are really getting squashed. So all those nerves are getting squeezed into that space, and that's painful. So, the end result, like a herniated disc, stenosis results in nerve compression, and nerve compression causes pain. And it does become more common as you get older. So whereas lumbar disc herniations occur primarily between 30 and 50, stenosis tends to be later in life. And even though it's mostly facet and ligament, so disc herniations can contribute, and sometimes you can have both. You can have some stenosis, and then you can herniate a disc on top of it, which can push you over the edge and make you symptomatic. So there's combinations of different problems that can work together. So stenosis, the classic symptoms are back and leg pain, which get worse when you walk and better when you sit. So people with stenosis can't walk more than half a block or a block, and they have to sit down. And when they walk, they get back and leg pain, or sometimes just leg pain, or they get a fatigue sensation in their legs or aching in their legs. And when they sit down, it goes away. And they can sit down for a few minutes and they feel better, and then they can walk a little more, and then they have to sit down again. And so that's the very typical or classical presentation of lumbar stenosis. And the shopping cart sign, which I've illustrated here, is very typical. And basically, if you have stenosis and you stand up straight, the stenosis gets worse. If you bend over, the space for the nerves opens up in the spine. So people that push a shopping cart often notice they can walk a lot farther if they're pushing a shopping cart. And so that's a very typical description of stenosis. Initially, it usually causes pain, but it can cause weakness or motor deficit and sensory loss, particularly when it goes on for a long time. And occasionally, people with stenosis can present with isolated back pain, but it tends to follow a pattern of increased pain when walking. That gets better when sitting. So again, non-surgical treatment is very similar to lumbar disc herniation treatment: therapy, NSAIDs, oral steroids, epidural injections, alternative treatments. The distinction is with stenosis, with classical stenosis, with facet enlargement and ligament enlargement, that does not go away. Disc herniations often go away. Stenosis is a one-way street, so it tends to get worse as you age and is more likely to become symptomatic as it gets worse. That doesn't mean you can't respond to treatment. So, if you have stenosis and you go to PT, you may get better, but it's less likely to be effective. And if you have more severe stenosis, you're much more likely to need surgery than if you had a lumbar disc herniation. So if we do surgery for stenosis, we do a decompressive laminectomy. What that is removing a portion of the lamina, which is illustrated here. We also shave down the facet joints because that tends to be the biggest part of the problem. So you remove a portion of the facet joints, but you can't remove the whole facet joint because that would make the spine unstable. But it's pretty straightforward to assess people with MRI imaging in terms of whether or not you can treat them with a laminectomy alone. In some cases, people need a fusion because we can tell from the imaging that they need to have entire joints removed, and we know we're going to make them unstable. But for typical spinal stenosis, you don't need that. Fusion is a whole nother discussion, which I'm not going to get into anymore here. In some cases, you do a discectomy as well as a laminectomy if there's a disc herniation as well. If you have a bulging disc that's sort of formed a bone spur, typically I'm not going to remove that. But if you have stenosis and then you have a herniated disc on top of it where it's an acute soft disc where it popped out at once, that's a situation where I may do a discectomy as well. And for a laminectomy, it's a little more extensive. Typically, you're getting both sides of the spinal canal. You're symptomatic on both sides. I do it minimally invasively for 1 and sometimes 2 levels, but if it's more than 2 levels, it's better to do it open. And, when I was a younger man, I did L2 to S1 laminectomies minimally invasively, and you can do it and it works, but it's difficult and it takes a long time. And so now I've become a little more selective in terms of when I choose to do it that way. So again, the greater than 95% success rate after a laminectomy, people often feel immediately better. People feel like they can stand and walk and their leg symptoms go away quickly in many cases, not all cases, but many. And it's very uncommon to have a recurrence, unlike a discectomy, unless you develop instability. And as I said, we're pretty good in deciding who might be unstable and might require a fusion. And in terms of risk, the risks are similar to a lumbar discectomy, other than there's less of a risk of a recurrent problem at the level of surgery. And so that's the end of my talk. It's very important when you're assessing the spine to do an appropriate exam. We see a lot of people with back pain. You want to watch out for things like this. So now I'll open it up to any questions, and I'd be happy to answer them. So here's a question. Age 81, 250 miles bicycling this summer, 100 miles walking. Pain is in the left hip and right lumbar region. 5 on a scale of 10. Do you have suggestions? I think that's something that needs to be evaluated. Most likely you need an MRI. It's very common to have hip problems which masquerade as low back problems, and low back problems which masquerade as hip problems. So I see a lot of people that come in and have been treated for their back or have been told they need back surgery, when in fact it's pretty clear that it's an arthritic hip joint, which is the ball and socket joint. You have one on the left, one on the right. And the symptoms overlap a lot between lumbar stenosis and hip arthritis. And so sometimes a simple hip x-ray shows bad arthritis, and that's a pretty obvious problem, and the physical examination is very obvious. Sometimes it's a little trickier. An MRI, an x-ray, physical examination usually will allow us to figure it out. Sometimes I figure it out myself. Sometimes I send them to one of my orthopedic colleagues to look at their hip. But most likely you would need to have x-rays and an MRI, and that would be the most productive way to go about assessing it. Okay, so the next question, how do facet joint injections fit into this picture? So facet joint injections are really done for low back pain, and which is really a different condition. So the facet joints are the joints in the back of the spine, which when they get arthritic and enlarge, push on the nerves and cause spinal stenosis, which we talked about. But facet joints also cause low back pain in some cases. So if they're arthritic or overloaded, basically they generate pain signals. And so if you have back pain without leg pain, then facet joint injections may help alleviate the pain. And there's different ways to do that. You can directly inject the joint with steroid within the joint, which can help with pain, but you don't want to do that a lot because it's bad for the joint, but you can certainly do it, once initially as a diagnostic measure and initial treatment. And then in some cases, they do radiofrequency ablations. The pain doctors do radiofrequency ablations, where they actually heat up the tiny nerve that goes to the facet joint and knock out the pain signals coming from the facet joint. And that can actually be very effective for relieving low back pain. But it is possible for someone to have spinal stenosis and have low back pain without leg pain, and it might be difficult to determine whether it's facet generated pain or spinal stenosis pain. And in that case, typically you would see how someone responds to an epidural injection and maybe facet injections, and you would go by their response to those treatments. So the next question, I had a laminectomy the end of July. What are my chances of having further problems with other discs? I'm a 74-year-old woman, spinal stenosis also. There's always a chance you could have another problem with another disc. So if you have a normal spine that has no instability and a typical laminectomy, the chance of you having another problem at the level of the surgery is very low. Sometimes people will develop stenosis at other levels, over time, because as we get older, things continue to degenerate. And, it depends on what you have now. I mean, if you have some spinal stenosis, we often see people that have varying degrees of stenosis, and in one spot it may be severe, in other cases not so severe. And you could do a big operation or a small operation for that, and I'll often choose to do the small operation to treat what I think is really symptomatic. But in some cases, what you don't treat may become a problem later. And then, so the next question, age 63, I have lumbar stenosis and an L4-5 disc herniation. Lifting is my biggest enemy. Any discomfort prevents me from falling to sleep without over-the-counter pain meds. PT is very good, but it's temporary. What would be your suggestion? That really depends. You should probably see someone like me for a consultation. I think a logical next step might be to try an epidural injection or a couple of epidural injections. And, it's possible that that could be very effective, depending on, whether or not you're overweight or fit or not fit. It's possible that, improving that may also help as well. But, typically if PT has not been effective, then you move on to other treatments, when they're appropriate and likely to help. So the next question, I have leg numbness and have been diagnosed with severe spinal stenosis, 76-year-olds in good shape. I can tolerate the situation now. What's the downside to waiting before doing a laminectomy? Which one of your surgeons recommended now? Well, I do laminectomy, so you can see me. We have 4 spine surgeons in our practice, and I would recommend any one of them. So if you have tolerable pain, you can wait. If you're starting to develop weakness in your legs or your feet, you can't wait, because people that develop weakness from stenosis and let it go too long often will develop nerve damage. And the older you are, the more likely that is to occur. So you don't want to let weakness go. So if you're starting to have trouble bending your toes up or your feet up, then you want to have that checked out and probably treated. If you have leg numbness, which is intermittent, goes away with rest or goes away, in certain situations, but comes on in certain situations, you can probably live with that. If you have constant leg numbness that never goes away, then again, there's a risk of nerve damage if you let that go too long. And so that's something that you would want to have treated. So the downside of waiting too long is nerve damage, which causes you to not get better after surgery. And it's just a question of severity in terms of how long you can wait. The next question, I have a burning sensation on the inside of both knees intermittently. Any relation with lower back and nerve problems, age 44? It certainly could be. There are different patterns of pain for different anatomic problems in different areas of the spine. And they don't always fit an exact textbook description. So it's definitely possible. So if it's a bad enough problem, then you should have an MRI of your lumbar spine to evaluate that further. So that's something you should have checked out. And the next question, I have spinal stenosis, a spondylolisthesis, and scoliosis. No leg pain, but numbness of foot and atrophy of calf. So, that's potentially problematic. If you develop atrophy in your muscles and your legs from stenosis, that usually means that there's been some significant nerve damage already. It really depends on the specifics. It's possible to have a disc herniation, have pain, weakness, and then have it get better, but be left with some atrophy without weakness. But if you have, atrophy and weakness from stenosis, then there's probably some damage there. And the same thing goes for numbness. So it depends how bad it is. If the stenosis is severe and the numbness is bothersome and you have weakness, then you should have surgery, most likely. If the stenosis is not really severe, that may not be the cause of the problem. And so in some cases, we'll do an EMG, which is a nerve test, to try to figure out exactly what's going on. And sometimes you can have other problems like peripheral neuropathy, which is a different kind of nerve dysfunction unrelated to the spine. But if it's severe stenosis with weakness and numbness or atrophy, then that's something that you should have treated. And so if there are no other questions, then thank you all very much for coming tonight. Oh, here's another question. I had a laminectomy in December and have had weakness in my right leg since, as well as low back pain. I was told healing could take up to a year. I feel like I'm not making any progress. That really depends on the situation. If you have a herniated disc with nerve compression and it's severe, that can do damage. And it's possible to have severe disc herniation and have damage that happens quickly after onset. And even if you have early surgery, if you're unlucky, you could have some permanent damage, which could lead to weakness or pain. But it can take a year or more for recovery to occur. So nerves regenerate at about 1 millimeter a day. So if you have nerve damage in your spine, it can take a long time for the nerve to regenerate all the way down to your feet or your legs. So it may take time. It really depends on the specifics of that situation. Certainly, if you haven't had any postoperative imaging, you should have a postoperative MRI, and in that case, you want to make sure that you don't have any nerve compression that is residual, or that you haven't developed a new problem like a recurrent disc herniation. So, that's definitely something that you would do. So if someone has surgery, and if I do surgery on someone for a discectomy and they are significantly improved, I'll usually give them between 1 and 3 months to recover. But if they're having significant residual pain or weakness, I'll get an MRI for sure to make sure that I'm not missing anything. And when I do it depends on whether they're improving or not. And so sometimes people improve for a while and then plateau, and then I'll get an MRI. If you got surgery and you haven't improved in the first couple of weeks, I'll usually get an MRI early on just to make sure that I'm not missing anything. So the next question, I have thoracic stenosis, previous pain in arms and shoulders. Is the treatment the same? So thoracic stenosis, it depends, but I talked about the spinal cord and how it ends at L1, and then the nerves come down off the spinal cord. If you have severe stenosis with spinal cord compression, then that can do serious damage and needs to be treated with surgery. So if your spinal cord is squeezed badly enough, it will be damaged and you will lose function, and that may not come back. So it depends on the severity of the problem. It depends on the physical examination. Most commonly, thoracic pain isn't going to give you pain in the arms and shoulders. If you have a thoracic problem at the C7T1 level, which is really at the junction between the thoracic and the cervical spine with nerve compression, that could give you pain in the arms and shoulders. And some people, there's different kinds of stenosis. So if you have stenosis with spinal cord compression, that needs surgery. If you have stenosis where the nerves coming off are being squeezed but not the spinal cord, then in some cases, that may be treated with therapy or non-surgical treatment. But the main distinction is if you have spinal cord compression, it's a much more serious problem than if you have nerve compression in the lumbar spine in most cases. And the threshold for surgery is much lower. And Mitchell Goldberg, thank you. Thanks for coming. What do I think about wearing a back brace? So a back brace is okay if you have acute pain. So if you throw out your back, you bend over, you lift something, you develop severe back pain, you have spasms. A back brace in some cases can be helpful in terms of just relieving pain and allowing you to get up and move around, and I think it's fine for that. Wearing a back brace on a regular basis over time will weaken your back because it weakens the back muscles. So you want your spine, your core, your muscles to support your spine. And if you use a brace to do that, then your muscles don't need to do that and you're going to get weak. So it's bad long-term. If you're a manual laborer that does a lot of lifting and you want to do it at work to prevent your back, I think that's reasonable and can be helpful, but it's not something you want to do all the time. And Sarah, thanks. It's my pleasure to have you here. Thank you for coming. So another question, do we offer consultations by phone? We offer consultations by telemedicine. You can also do it by phone, but so with telemedicine can be helpful sometimes. We do it like sort of this kind of a platform with video and audio, and so we can certainly do that. And if you want to look into that, then you should just call our office, and then someone can help you arrange that. But we do that. Thanks. So yes, this is recorded, and you will be able to view it later. It is recorded somewhere. So it's posted on our website. Here, this is the link for recordings for webinars.